Today, in this Ask the Session author, it is really my great pleasure to host Professor Kudo for his recent publication, TACE combined with lenvatinib plus pembrolizumab versus dual placebo for unresectable, not metastatic HCC LEAP-012. So first, Professor Kudo, it's really my pleasure to have you with us today, and congratulations to you and your co-author for this important paper. And the context is that in hepatocellular carcinoma, we treat patients with local therapies, and we have the idea for years to combine with systemic treatments. We did that with the TKI, for example, with sorafenib. All the studies have been negative. And then we have the Emerald trial testing, a combination of TACE with a systemic treatment, which came positive. And now we have your trial, which is also, as you will show us, positive. But I would like first to ask you to give us a few words on the design of this trial.
So you asked me the trial design of LEAP-012. The LEAP-012 was lenvatinib plus pembrolizumab plus TACE versus dual placebo plus TACE. So intermediate stage, in other words, hepatocellular carcinoma without vascular invasion or extrahepatic disease. Those patients were randomized 1:1 to lenvatinib plus pembrolizumab plus TACE versus dual placebo plus TACE. So the primary endpoint was PFS and OS. But this dual primary endpoint is first PFS positive, then OS will be tested. So either one is positive, the trial is positive. Very important point in this trial is the stratification factor. Of course, it includes AFP value greater than 400 or less than 400 nanogram per ml, and also tumor burden score up to 6 criteria, up to 6 or 6 to 12 or over 12. This is very important, and also RB grade. Those are included in stratification factor.
Just a clarification. So you had the TACE sessions. Did you allow the treatment between TACE session, or did you begin the systemic treatment only when all the TACE sessions were finished?
Different from other trial, this LEAP-012, the lenvatinib plus pembrolizumab was introduced 2 to 4 weeks before first TACE. Then TACE, after TACE, lenvatinib plus pembrolizumab was continued until progression over this. So because lenvatinib contains anti-VEGF activity, and anti-VEGF improve TACE efficacy because anti-VEGF normalize abnormal vessel and the drug delivery is improved. So TACE efficacy is improved, and also the TACE induces hypoxia, and which induces vascular endothelial growth factor, VEGF, increase the anti-immune cell like regulatory T cell or tumor-associated macrophage or MDSC, myeloid-derived cells. So, and also inhibits the dendritic cells or CD8 positive T cell infiltration into the tumor. So in that sense, before and after TACE, the lenvatinib was introduced. Those points is very important, different from other trials.
Yeah. Let's differentiate this effectively, this trial. And what were actually the primary results of this trial?
Primary results was positive. PFS met its primary endpoint, and hazard ratio was 0.66. And also OS events are very immature, but still the OS beta trend was shown. Hazard ratio was 0.80. So the results was very good.
So now, Professor Kudo, we have two phase 3 trials positive,
Yes.
One with your very interesting design combining already before the TACE the treatment. So do you
Mhm.
think the is really something which should become standard of care, that now when we do TACE we have to add systemic treatment?
Yes, I think the non-metastatic
Mm-hmm.
HCC, maybe we should. This combined with IO plus anti-VEGF should be the standard care.
Yeah. Yeah, yeah, this really changing the field. That's very important
Yes,
because
yes,
there is a benefit for the patients to add this
yes.
combination, which actually
Mm,
is safe and tolerable. So really, thank you so much for taking the time to
thank you.
discuss with us this important publication, and wish you a good day.
Thank you.
Be part of the future and join our fight against liver cancer.